The introductory part regarding the dislocation has already been covered by Dr. Erika in quite detail. Mostly anterior, so I'll just brush it up. Mostly anterior, more than 95% of the dislocations. Posterior dislocations are about 3%, less than 5%. True inferior dislocations are less than 1%, and habitual non-traumatic dislocation which may present at multidirectional dislocation due to generalized ligamentous laxity and is painless. So, as pointed out, because we are struggling with all the other and multiple, I mean, a gamut of confusion. So the clinical examination and the radiological examination can give us an effective treatment plan. Why? Because we are dealing with the power generators, which are positioning the shoulder in the 3D space, resulting into a force transmission. So establishing a kinetic chain, and whenever instability happens, there is a breakage in the chain. And most of the times, all of us are treating patients who are athletes who have got an angular velocity of close to somewhere around 7,300 degrees per second, where all the major muscles are acting, and there is a lot of angular momentum in them. So instability in them will be different than someone who is a sedentary worker. So the assessment, the clinical examination, though the test will be the same, but the impact and the treatment will change. And about the deceleration, there is about 750 newtons of distraction forces occurring at deceleration. So the injury and the instability will be different. And we have to deal with the Thrower's paradox while stabilizing the shoulder, because it needs to be lax enough to allow excessive external rotation as well as stable enough not to dislocate the joint. All these accelerations in different will be having associated lesions, as pointed out by Erika. So they will have Hagel lesions, they will have Glad lesions, they will have Elsa lesions, they will have Boni Bankart lesions, and other nomenclature lesions. But in all, what the patient wants is a stable shoulder. So I'll just brush it up, the Madsen classification. So we need to really have our questions right. Okay, what are our questions? What are we going to ask? So history of previous dislocations, whether the dislocation was because of a major trauma or a minor trauma, and what is the range of movement? How was the dislocation? Did it occur in sleep? The spontaneity of dislocations, whether the patient was aware of the hidden subluxations, and the history of dead arm. They will point us towards the hidden pathology in shoulder, and then subsequently we can find out what exactly we are dealing with, whether we have to really only a scopy will help or open procedure is required. And what are the red flags? History of a very high velocity trauma, tenderness, pain, restricted movements, abnormal mobility, dislocations in sleep, and MDI, of course. The physical examination part, we need to inspect swelling, wound scars, sinus, muscle atrophy, asymmetry, tenderness, strength of the deltoid and the rotator cuff, and the scapular stabilizers. Is there any obvious muscular atrophy? Then more extensive motor sensory and disturbances that can suggest a brachial plexus pathology. Whether the patient is having increased passive external rotation with the arm at the side and reduced external rotation in 90 degrees of abduction, that may indicate a medially healed Bankart lesion. We need to see the Brighton criteria for the global tissue laxity by examining the glenohumeral translation and the hypermobility of other joint. The apprehension test is the workhorse. When the pressure is applied on the posterior aspect of the humerus on 90-degree flexion and 90-degree external rotation abduction, the patient feels some amount of apprehension. And if you put anterior pressure on that, downward pressure, they reassure. There is a surprise test which has been said to have a 99% of specificity once you suddenly remove that arm, and that can give us a clear indication in clinical examination about anterior instability of the shoulder. So the subluxation part, shoulder in 0 degree of abduction, one hand on the scapula, We grasp the humeral head with the other hand and apply a compressive force and check for the amount of anterior and posterior translation. Easy subluxation of the shoulder indicates the loss of glenoid concavity. The sulcus test, pulling the extremity distally, observing for sulcus or dimple on the shoulder that doesn't reduce on 45 degrees of external rotation. Now, grade 1 is subluxation less than 1 centimeter. Grade 2 is 1 to 2 centimeters. And grade 3 is more than 2 centimeters. Subluxation at 0 degree of abduction indicates rotator interval laxity. At 45 degrees indicates inferior glenohumeral laxity. Arm in 90 degree forward flexion, internal rotation, we check for the posterior subluxation and test for instability. Similarly, for the anterior instability, and we grade it as grade 1, 2, and 3. Now, in radiographic evaluation, though we have got CT scan, but the patient seldom comes with these X-rays now with you with a dislocated condition, unless it is a chronic condition. Someone has already relocated it. So we need to have a straight AP radiograph in external rotation, the straight shoulder in internal rotation, a Garnier view, which will give us idea about the scapula, the axillary view, the Bernaghe view, which will give us the glenoid profile in the anterior posterior direction. You can see in the figure B, after relocation of the shoulder, there are loose bodies, and there is a small inferior glenoid bone loss. Okay. D is posterior dislocation, which is missed in most of the cases with a anterior Hill Sachs, and this is a luxio erecta after a car accident. So X-ray has its role in diagnosing dislocation. Posterior dislocation is most of the times missed on X-ray evaluation. So for that, we need to do CT scan. These are the other views in which how they need to be taken for the general audience. This is the axillary view of the shoulder taken in X-ray beam is projected through the axilla with the shoulder in 90 degree of abduction and the plate above the shoulder. It gives us a clear visualization of the humeral head with no superimposition and the relationship of the humeral head to the glenoid. You can assess for the glenoid bone loss anteriorly as well as posteriorly, and the assessment of the acromion and the coracoid process. This is the West Point view. The patient is lying prone. It's a modified axillary lateral view with shoulder abducted in 90 degrees and elbow bent over the arm hanging over the table. The X-ray beam is directed 25 degrees medially and cephalic. It shows calcifications or small fractures at the anterior inferior glenoid rim. The striker notch view, patient in supine position, elbow elevated over the head, is directed 10 degrees cephalic. It shows Hill Sachs lesion and the Bernaghe view. It helps in measuring the distance between the anterior and the posterior glenoid rims on the anterior posterior axis. So, but now this has been lot supplemented by the CT scan. So multi-detector CT scan, it helps us to evaluate the bone defect and bone loss and to evaluate the type of lesion, subsequently helping us decide the type of surgical intervention which is going to need needed. So as you can see, a posterior Hill Sachs lesion, anterior bony Bankart, and an engaging Hill Sachs. So Hill Sachs lesion in this can obliquely oriented in the neutral view, which becomes parallel on the anterior labrum in the abduction position. And sorry, excuse me. So basically, we can determine the amount of bone loss with the PICO technique, with the CT scan or the multi-detector scan, by centering the central circum method and by calculating the amount of bone loss. So the percentage of bone loss can be calculated by this formula. A is the surface of area of the best circle fit. B is the surface of the contralateral glenoid. And then about the glenoid lesion of the Hill Sachs, and is lateral to the medial margin of the glenohumeral tract. The medial border of the off-track Hill-Sachs lesion overpasses the medial margin of the glenoid tract. C shows the articular loss and a total articular measurement. This concept was very well explained by Professor Yamamoto, in which the glenoid bone loss on the on-track on the off-track lesion, and thereby we can supplement it with Latarjet.
Speaking about shoulder dislocation, we need to be aware of the concept of glenoid tract with the arm in various degrees of abduction, maximum external rotation. Okay.
So, am I audible? Excuse me.
Yes, Ajay. There was a problem with your voice, but now it's perfect.
So Professor Yamamoto described the on-track and the off-track lesion based on the location of the size of the humeral defect and the amount of bone loss. It has a very high predictive value in clinical settings, determining the type of surgery that will be needed. If it is more than 19%, 19 to 20%, we have to do a bony procedure to supplement the loss of glenoid. If it is less than that, a soft tissue procedure with a remplissage will help. Off-track lesions can result from either a large bony Bankart lesion or a Hill-Sachs defect, or from combination of a moderate size Hill-Sachs and a moderate bony Bankart. The two factors determining the lesions are the anterior inferior glenoid bone loss and the Hill-Sachs interval. Hill-Sachs interval is the addition of Hill-Sachs defect per bony bridge between the rotator cuff attachment and the lateral aspect of the Hill-Sachs defect, and it is measured in the axial plane. What are the implications?
What is the implication? If the Hill-Sachs lesion stays on the glenoid tract, on-track lesion cannot engage the glenoid and cannot cause dislocation. On the other hand, a Hill-Sachs lesion which is out of glenoid tract, which is off-track lesion, has a risk of engagement and can result into dislocation. The area of Hill-Sachs lesion can be measured on a CT.
Coming to this MRI resonance imaging, it is the workhorse and the most sought after treatment. There is some debate about use of gadolinium for assessment of the capsular tears, but as you can see, it can very well show you the amount of Hill-Sachs. And then this is a capsular laberal complex which can be easily evaluated on the MRI, and you can see the different types of lesions: the anterior lateral lesions, the Bankarts, the Perthes, the ALPSA, and the GLAD lesion very well on a MR orthogram. So now MRI orthogram is the gold standard. Coming to the humeral avulsion of humeral side of the capsulohumeral tear, it helps in understanding the posterior band, the inferior glenohumeral ligament tears, the tear of the axillary hammock, and the from D to F, you can point out on the MRI the various MDI associated lesions of the inferior glenohumeral ligament tear. At the same time, it gives you an idea about the posterior labral pathology, the posterior bony osseous lesions, the Kim's lesion. It is a concealed lesion of the posterior labral complex. If we miss the Kim's lesion, then and only operate on the anterior Bankart, there are 85% chances of recurrent instability. With this, I would like to say that instability is a complex scenario where you need a combination of a clinical and radiological assessment. MRI being the workhorse, but still the role of X-ray and CT scan is there. CT definitely to understand whether the lesion is on track and off track and make a proper call for the treatment. Thank you.